Hi, my name is Alex Greninger, and I'm associate professor at the University of Washington here in Seattle in the clinical virology lab. And we're doing an ASM brief on different aspects of antiviral resistance testing. So this one's on HIV. So basically what I want to talk to you about is how antiviral testing is done on a very high level for HIV. HIV is unique in that there is antiviral resistance testing recommended at the time of initial diagnosis. So basically everyone getting a diagnosis of HIV is getting antiviral resistance testing through genotypic sequencing rather than phenotypic testing. And this is done via sequencing of the protease, polymerase, and integrase regions of the HIV virus. This is here from the HIV treatment guidelines indicating this initial diagnosis testing, as well as the requirement for genotypic testing. Similar to other viruses, this is unique about HIV, but similar to other viruses, we also do HIV resistance testing in the context of virological failure. So individuals who have breakthrough of especially greater than 1,000 copies mil or 500 copies per mil, and then some evidence for greater than 200. So any really evidence of virological failure is indicated for drug resistance testing. And again, we're doing reverse transcriptase, protease sequencing, as well as integrase area sequencing if you have an integrase inhibitor-based regime. There are so many HIV drugs that in a quick little brief like this, we really don't have time to go through all of them, but basically almost all areas of the life cycle now are subject to potential inhibition with co-receptor antagonists, fusion inhibitors, new capsid inhibitors. We have sort of the now considered old school, but still part of the major treatment regimes of the nucleoside and non-nucleoside analog reverse transcriptase inhibitors. Integrase inhibitors have an increasing role to play, as well, of course, the protease inhibitors were one of the major classes that came out in the late 90s that were so key for control. And these individual drug classes are combined in many different ways in these combinatorial antiretrovirals. Again, from our NRTIs, protease inhibitors, entry inhibitors, and integrase inhibitors. When we do HIV antiviral resistance testing, we are mostly sequencing. So we're amplifying. Here's how our lab does it. We amplify protease and RT, as well as integrase, do a second round PCR to get enough material and to help the analytical sensitivity, send it out for Sanger sequencing, and offer you an antiviral resistance report after running it through an interpretation engine, which of course here is the Stanford HIV database, which is really the standard for interpreting genotypic resistance with so much data that they have. And that's basically how we get it done for HIV antiviral resistance testing on a clinical use. I'd also like to throw out that increasingly there's now FDA authorized testing available for HIV. And the other thing is that there's more public health uses of this data. This is a little bit old data, but now most states are submitting antiviral resistance testing for public health epidemiology purposes. And there have been a number of use cases where the CDC and local public health jurisdictions have made use of that data to find additional cases and help with their tracking and control of the HIV pandemic here in the United States. And this is also being done globally. And this is increasingly a new use of antiviral resistance data to feed into sort of a public health purpose as well. And that's the end of this brief. I thank you so much for listening, and I'm happy to talk to you offline. Thank you.